most common type of pain that we deal with. When we look at nociceptive pain, I want you to break it up into two. You've got somatic versus visceral. When you're looking at somatic, soma is Latin for body, right? So this is your aches. This is if you accidentally, hit your hand against something and it's constantly throbbing. It's the swelling, it's the bruising that you can physically see. The visceral pain is going to be from within. So this is someone who says, you know what, my back really hurts, but it feels like it's within. Maybe when you pull a muscle, you feel this type of pain. Other types of visceral pain that we usually see are also going to be from our anemic clients. So a lot of them, a lot of people who have anemia, when you get cold or when you feel a gush of cold air, you know how some people say, I feel cold to my bones, or like my bones are really cold? That's visceral. So it's not really something that's actually causing it, it's just from within. So that's going to be visceral versus soma. Between the two, what's easier for us to treat? Soma. It's always going to be soma because we can see it and we can try to heal it, right? If someone says, oh, this gust of cold air is, it's a chill in my bones, you can't do an x-ray, you can't ultrasound it, you can't see it. But for the somatic pain, we will be able to see some sort of damage to your client. Then we've got our neuropathic. So neuro is nerves. So here we're going to have nerve pain. Nerve pain is going to be damage to the nerves or whenever your client has a CNS change. So if you guys remember from third semester, you guys learned about Parkinson's, MS, Alzheimer's. Those are all CNS changes, right? So with those, we can possibly see neuropathic pains. Now, with neuropathic, here your client is going to verbalize that they feel the burning, the shooting, the stabbing, or just constant electrical pain to a certain area. With neuropathic pain, do you think this is easy to treat? No, why not?
CNS.
Because it's CNS, exactly. So with neuropathic, it becomes trickier for us to actually treat. Here, you can try using opioids, but a lot of times the opioids, they don't take away the pain, right? In comparison to a somatic client. Here, we're going to have to use a lot of alternate meds. So here, we love using gabapentin. We like to use meds that maybe we give for our seizure clients or Parkinson's disease, along with some Tylenol and then maybe some opioids as well. So this client's going to have multiple different meds that we're going to give to treat their pain. And then lastly, we have acute versus chronic. We should all already know the difference between the two. With acute, we love to do opioids. We will give it. Once your client heals, we take them away, right? That's really our acute pain. Chronic pain is not really adaptive. So chronic is going to be persistent. Sometimes we know why it's there, sometimes we don't. With chronic pain, what makes it also a little bit more complicated is that your patient will probably have some sort of anxiety related to that pain as well. So maybe they're anxious about going to work because when they go to work, then they get more pain from perhaps using a certain body part. So that's where we're going to see the difference between the two. Because we have anxiety and possibly depression being integrated with chronic, your meds are going to be different. So again, we still have our opioid versus non-opioid, but then we're looking at things like anti-anxiety and our antidepressants. Does this make sense? The different types, yes? This next slide just goes over our pain assessment. I won't go through the full shebang because we should all already know this. Out of all of these, what do we prefer? What type of pain assessment is the best, I guess? Which one?
Can you repeat the question?
The ones up there?
Yeah.
Oh,
yeah,
okay.
from the ones up here. Sorry, yeah. From the ones up here, what pain assessment would probably be the best for your own nursing?
Probably the first
Scale
one.
of 1 to 10.
The scale of 1
The
to 10,
scale.
absolutely. And then what do we add with the scale of 1 to 10?
one we know.
Yeah, so your PQ or STU, right? So both of these two are going to be our ideal pain assessment for our client. We want to know on a scale of 1 to 10, because then when we treat it, we want to see if it's getting better. So we always want a baseline, but then we're going to do our full PQ or STU. When we do that, that's how we're going to understand the type of pain your client has. If you just do a scale of 1 to 10 and your client says it's a 5, that doesn't tell you if it's somatic, doesn't tell you if it's visceral, doesn't tell you if it's neuropathic, right? Your PQ or STU is going to tell you that. And that will change the type of meds we give. So that's why the PQ or STU is so important when you're doing your, especially that initial assessment. The goal here is, of course, to identify the type of pain, and then it's going to lead us to how to treat the pain. So, treating pains, we've got a couple terms here that I do want you guys to highlight and know for your exam. So the first one here is an equianalgesic dose. So equi means equal, analgesic is your pain med. So it's an equal pain med. Basically, what this type of medication is let's say your client is taking Tylenol 1,000 milligrams. They're taking it, but it's no longer working for them. The thing that we're going to try doing before we increase them to a different type of medication is, you know what, let's try Advil instead. We're not going to go Tylenol straight to a Percocet, right? We're going to try something in between. And an equianalgesic dose basically means here's the medication and here's something that works on an equal level to it. And we're going to try swapping them out. So instead of giving Tylenol 1,000, maybe I go ahead and I give my ibuprofen 600 milligrams to my client and I see if that works better for them. So you're giving basically the same level of medication, but just a different type. If you go ahead and you give that Advil and it's still not cutting it, then we probably have to go a little bit higher, right? Then we'll have to try maybe a stronger non-opioid, or we do switch to an opioid. But we go to the least, the least narcotic opioid, I guess. And we're gonna go over the levels of them. So that's your equianalgesic. The second type here we have is scheduling, and we should all be familiar with it, right? You guys have all done this in clinical as well. You go onto your unit, it's 8 o'clock, your patient is scheduled, whatever medication, you go ahead and you give it. With the scheduled analgesic, the goal here is to basically continuously give it to your client to keep the pain at a lower level. If we give a whole bunch of medication and then we kind of leave this patient all day, their pain's going to come back, right? Or the pain's going to get worse. So we are going to continuously go and treat their ongoing pain. We then have our breakthrough meds here. What is breakthrough?
It's like you're already on a pain medication, but then even after taking it, you're still in pain.
You're still in pain, so what are you gonna do?
Breakthrough medication, which is like a different, less potent pain medication that you take just to deal with the aftermath of the pain medication that you're on.
Yeah, absolutely. So it can be a different medication. You also had your hand up?
I'm gonna add something on, but it's okay.
That's okay? Okay, perfect. So I'm gonna write on the board really quick, so I want it to be very clear for all of us, the difference between the two. So your scheduled meds, let's say you've got 0800, you've got 12, and you've got, what would be the next one, 16? This is going to be your scheduled med. Let's say we go ahead and our schedule is going to be hydromorph 2 milligrams. It's there, and it's there. Now you come into your patient's room at 10 o'clock and they say, you know what? Here, my pain is still a 7 out of 10. It was 7 out of 10 when you started, it's still a 7 out of 10. Are we gonna let them go to 12 in that same pain? No, right? This is where your breakthrough comes by. So your breakthrough can sometimes be the same medication or it'll be a different medication. Usually it's the same med, but a lower dose that we're going to give. That is usually the most common breakthrough you're going to see. And basically, your breakthrough is going to be ordered as PRN, right? Because it's no longer going to be and then maybe at 2 p.m., you give 1 milligram once again. So we're always going to be giving our client something in order to control that pain. Now, in this case, what are we worried about for our patient? Overdose. What are we going to do? How do we assess for it?
Check their kidney function? Or
You could, yeah. So first of all, you're absolutely right. If you're giving this amount of hydromorph, we want to make sure they're able to clear it, right? So we'll do all of our kidney tests. But what do we do throughout the day?
Respiratory.
Respiratory? That was what you were going to say, respiratory? Perfect, yeah. So here your rest rate and your oxygen sat are going to be crucial. What else are you going to do on top of that? You can do a pain assessment.
CNS.
Your CNS. So here you're going to check for your LOC. Are you still alert and orientated? Is this client more drowsy, or are they completely fine with the medications they are receiving? So that's going to be your breakthrough and your scheduled med. The important thing to note with both of these is that they're going to be 2 separate orders. So your scheduled med will be separate, and then your breakthrough will be a separate order. You can never just decide, you know what, at 6, instead of giving 2 milligrams, I'll just give the 1 milligram. We don't get to do that, right? If it's ordered for 2, we can only give the 2 milligrams. Then we have our last one, which is titration. And titration is basically, we will increase or decrease the dose depending on your client's pain. When do you think we would titrate? In what cases?
When they're about to be like discharged?
And what do we titrate to? Up or down?
Down.
Down, absolutely.
Or like in cases where like abrupt stopping is bad, you titrate it down kind of slowly instead of just stopping it completely.
Absolutely. So we always want to wean off our patient, especially if they're on a high dose of narcotic. When else would we titrate? When would we titrate up?
If the pain's getting worse.
If the pain's getting worse, when else? What are some scenarios that we would titrate?
Like oxygen?
Say it again.
Oxygen, like if someone's oxygen was dropping?
If they're dropping, yeah.
Yeah.
So maybe you give the hydromorph, their oxygen drops, then instead of actually titrating, we would probably remove hydromorph altogether and give them a new med, right?
Yeah.
Absolutely. What about our surgery patient? We usually titrate up, right? When they come back from surgery, we don't say, okay, I'm gonna start with Tylenol, and then I'm going to give you, 1 milligram a little bit later if you don't feel better. When they come back from surgery, we give them narcotics right away because we expect that pain. Cancer is going to be another big one. So this is something I want you to remember for the very end of the semester. For our cancer care clients, especially those who are palliative, we are going to always titrate up, right? We very rarely will titrate down any of those doses. Does that make sense? Yes? Okay, beautiful. This is our WHO analgesic ladder. So this just emphasizes the different meds, the different approaches, and how we want to, treat our clients' pains. So the first step here is going to be our non-opioids or any type of client where there's mild pain involved. What are some non-opioid things we can do for our client? How can we treat their pain?
Medication? Like non-
non-pharmacological or
yeah.
You can do both. So give me non-pharm first. How about that?
massage?
Yeah, you can do massage. We can do ice or heat therapy. What else?
Distraction.
Yeah, distraction, absolutely. So sometimes they use like the guided imagery or like the music therapy, absolutely. So those would all be your non-pharm. Another big one is going to be elevating. So elevating a limb is going to be a big one when it comes to non-pharm interventions. What about medications? What meds can we see?
I don't know.
Tylenol, absolutely. Tylenol, Advil are usually our big ones when it comes to non-opioid related. We do have a list that's going to come up in the next slide, so we'll go more in depth there. Step 2 is where the pain is going to start to add some sort of opioid into the mix. If still we don't treat it or the pain is not being controlled, then we go up another level and we give a much more higher dose or a stronger opioid to your client. Usually we don't stay in box number 3 for too long. We will always go up and then we will come down the ladder as well. So if your client's going on 2 milligrams of hydromorph, you're not discharging them with nothing for pain, right? We are still going to titrate them down. Maybe we do a smaller dose of hydromorph, or we give them Tylenol, Advil, Ketorolac, something that's non-opioid related, and see if that manages their pain. And then we will discharge them. This table here, I've tried to create to show you guys the different types of meds for the different types of pain. So for mild, acetaminophen or Tylenol, of course. We've got our ASA, which is what?
Aspirin.
Aspirin, beautiful. Ibuprofen, which is your Advil. What is Ketorolac known as?
Toradol?
Toradol, exactly. What is Ketorolac? Do you know?
It's like a really strong medicine.
Exactly. I always think of Ketorolac as a super intense version of Advil because it works with just decreasing inflammation. The really cool thing about Ketorolac is you can give it through the IV. So your clients who are post-op, especially ortho, Ketorolac works wonders because it decreases the swelling systemically for your patient. What is diclofenac?
Voltaren.
Thank you, Voltaren. And what is that?
It's basically like an ointment for your like joint pains or like arthritis.
Yeah, absolutely. So here, usually we see it for joint or muscle pain for your clients, right? This, I'm sure you guys have all seen, even in your Shoppers, Costco, you can get it over the counter as well. And then what is this last one that we have here? Has anyone given Celoxib in clinical before? It's like a white with yellow stripes. It's a very intense ASA. So this is going to be your best ASA that we can give in the mild category for your patient in terms of a pill. So this works really well for clients, and we do usually, like this is never just a one-time dose. This is something that your patient's going to take with their entire medication regimen, usually for a set amount of time. Under the moderate area, we've got our codeine, of course, which is an opioid. Codeine is known as probably one of our weakest opioids that we have. Codeine, we know, can be taken in pills, but usually we see it in liquid, right? Your physician might even give it to yourself or to any of your family members if they're having really, really bad cough or if they're having lots of pain, so it's usually given in a liquid format. The next one we have is tramadol. Does anyone know what tramadol is? Does anyone know what Tramacet is? Yeah, you're absolutely right.
The beta blocker?
Oh, not a beta blocker, sorry. I misheard you.
Or normal beta?
Acetaminophen?
There is acetaminophen in it, absolutely. Basically, tramadol is another form of opioid, but it's going to be given as a pill. Tramadol and Tylenol put together give you Tramacet. So Tramacet is the one that we love to give post-op to our clients because it's both the Tramadol and your Tylenol put together. So this medication, you want to do lots of teaching to make sure your patient doesn't take extra Tylenol when they're home, right? Because we already know it's within that medication already. And then we've got our butorphanol, which is basically given for migraines. It is a very, very good medication that we will give nasally for your clients who have really bad migraine pain. Then we've got our severe. So all of these meds in severe are of course going to be our strong, high-dose opioids. So here our big thing is always going to be respirations and our LOC for our client. What medication are we going to have on standby for this Exactly, naloxone, right? So if your client overdoses, we give them Narcan. So we make sure we have it on our units, which we all should. And then if your client's going home with this prescription, we always recommend them having Narcan with them, especially if it's a big dose. Here we've got our morphine, hydromorph, your oxys, your methadone, your fentanyl, and your Percocet. What makes up Percocet? Percocet and Tramadol are very similar. So you have Tylenol added in, but with Percocet, instead of Tramadol, you use oxycodone. So that's going to be your combination. Your oxycodone and your Tylenol put together give you the Percocet. What is the other term for hydromorph? It starts with a D. Dilaudid, absolutely. So Dilaudid is going to be the other term that usually you will see for your hydromorph. All right, so you've got your patient with, let's say, some form of narcotic. How are we going to address addiction? Because it can happen, right? Possibly. Sometimes your clients, post-operatively, they'll refuse to take any type of narcotic because they're afraid of being addicted. What type of teaching can we do?
Take as prescribed, follow the label, don't overtake, discard if anything's remaining.
Perfect, exactly that. So take as prescribed, right? That's always going to be your big thing. If your client's 1 to 2 milligrams, we can always advise them, take the 1 milligram, see how you feel. We will always start giving the medication in hospital. We never let them take the first dose by themselves. And we will monitor for any side effects. Also, when your patients are discharged, we will usually send them with a very limited amount of the narcotic. So it's not like they get to go home with a month's supply. It's usually only good for a couple of weeks, and then they have their follow-up with their surgeon, and then they will go based off that if they give more, if they withhold, or if they give a different prescription to your patient. Here, we always need to make sure we do our substance screening for our client as well. If we know they do have an active history of addiction, probably not the best idea to give them a high dose of a narcotic, right? So here we will try our best to give non-narcotic meds, or what is our equal analgesic dose for a narcotic? What do we give instead? If someone is addicted or has dealt with addiction in the past. Starts with an N.
Is it methadone?
Methadone, exactly. Methadone we usually give if your client is currently using. We will give them an equal analgesic dose of methadone for their pain. If your client has a past history with addictions, most likely they will not take the opioid meds, nor do we recommend it, right? For this client, we will probably do a lot of non-opioids, but we will do it a lot more frequently. So for example, instead of just giving a pill of Advil, we'll probably hang ketorolac for them, right? Instead of giving them just one pill of Tylenol, we'll give the full 1,000 milligrams. So we're going to use lots of other non-pharm meds to supplement this client's pain regimen. Does that make sense? Yeah. Other meds we can give. So we've got our antidepressants. This works really well for adjuvant therapy, especially if your client's on a medication for chronic pain. And usually the antidepressant that we'll give are the tricyclic antidepressants for your client. We've got our anti-seizure meds. Your big one here will always be gabapentin. We love giving gabapentin, especially for nerve pain. It is very effective. We give our corticosteroids. What are some examples of those?
Dexamethasone.
Dexamethasone,
Prednisone.
prednisone, and your Medrol. So all three of those will help with decreasing anesthetic, usually it's going to be given for nerve pain. Local anesthetics, we don't really offer, I guess, easily to your client. It's only if they meet certain protocols or certain requirements that they can get the local anesthetics. Usually local anesthetics we give to our older adult clients when they have a lot of other comorbidities or other reasons for that chronic pain. And then lastly, we have our ketamine. What is ketamine classified as? Because it's not an opioid.
Is it a horse tranquilizer?
It can be used in it, yeah. What is it known as? Or not known as, but what is the category for it? Say it again. It's an anesthetic, yeah. So this is where your horse tranquilizer comes in play. So it is an anesthetic for your client. So here we are going to absolutely be very careful when we give ketamine, because if we give too big of a dose, you're going to have anesthetic impacts to your patient. All right, then we've got our surgical therapy. So this will all be a recap from last week. So you guys tell me, what's a PNB?
What?
Your peripheral nerve block, what is it? Not an epidural.
I do.
You want to give it a shot?
It's where you're actually doing like a regional area, so like one part.
I agree.
Yeah.
Yes.
Exactly, you're completely right. So for your PNB, this is where, let's say your client got an amputation. Let's say it's the left arm. Let's say it's the left hand, sorry. We are going to do a PNB, which is a nerve block, into that one area. So usually with a PNB, it is going to be a needle that we go ahead and we place in to a certain nerve. We have a little small IV box, and it's going to continuously give anesthetic to that area so it numbs it for your client. PNBs are given in a very severe case only. So usually it's to do with amputations or when your client has gangrene, so we know an amputation is coming up. PNBs, very effective because we go straight to the nerve. What are our assessments going to be?
Bromage.
Perfect, your bromage and your,
And you do the dermatome.
perfect.
With the ice.
Exactly. We will always do both. So you guys remember from last week, dermatomes and your bromage scale. Very crucial for your PNB. Dermatome, walk me through it. What is a dermatome check? You guys remember?
It's like you put the ice like where it is, and if they tell you they feel it.
How do we start it though? How do we start the dermatome check?
On the face.
Yeah, exactly. So basically with a dermatome check, you can't just assume, right? We're doing a full assessment. So you start on the face on one side of the body and you tell your client, does this feel cold? They say, yes, it does. You then tell them, okay, if it ever feels less than this amount of coldness, you let me know. And that's when the numbness has started. So we start on the face and we go all the way down the body. Let's say I get to my hip and I say, oh, you know what, Kieran, I can't really feel it that much. I mean, it's still cold, but it's less cold. That's when you have decreased sensation and you keep going down their body to see if the sensation ever returns. That's your dermatome check. You do one side and then you always compare it to the other. In your PNB, your dermatome level will never be equal, right? Because in a PNB, we're decreasing sensation to one area only. So on my right side, I should have full sensation, but on my left side, I'm going to be decreased sensation, right? And in this case, it will be normal. If you give an epidural, or if you give a spinal block, and it's ever abnormal, that's when we're going to be a little bit worried. Because normally, it should be pretty equal for your client. If you start doing your epidural checks and you start going down and you find that they're abnormal, what are we first going to do to our client? laying equal on both sides. And then we do the checks down their body. And then lastly, we have our PCAs. What is a PCA? Yeah.
It's just a control of the discount of the patient controls how much of the medication they're getting based on how much they're getting.
Exactly. So with your PCA, it is crucial that the patient is the only person who presses that button to get the medication. If your client has a PCA and they have decreased LOC or they have a lot of pain but they're not pressing the button, probably not appropriate for them, right? We've got to swap out how we're giving them their narcotics. Family members can't push it, nurses can't push it. It always has to be the patient. Any questions here? Yeah.
Do they ever give peripheral nerve blockers for like knee surgery?
Mm-hmm.
Because I've seen that before.
Yeah, knee surgery is a big one. We love it for ortho. Ortho procedures and vascular procedures. We love giving PNVs for because they're very effective.
And you have to do like a dermatome check and everything still?
For PNVs, you will always do it with your initial assessment. Afterwards, we don't really do it. But if you're the first, like if this is your first time with this client, you will always start off with it. And then as you reassess, you don't have to continue because you know it's only going to one area. If you have your spinal client or your epidural, you're redoing it every 4 hours usually. Any other questions? All right. Our non-farm. So we've already started talking about a few of these. So we've got our massage for our client. I always say massage is an iffy one. If you have a client, you have to first see what is hurting, what is going on with them, and is a massage appropriate? So for example, if you have a client with hip surgery, are you going to go massage their hip? No, right? We're gonna leave it alone. We're not massaging it. We're not dislocating anything. If your client just has a sore back from laying in bed, we can absolutely go ahead and try to give them a little bit of a rub. So it's always going to be situational. We then have exercise. So with exercise, we just try to promote some sort of ambulation with our clients. So usually walking 30 minutes is our goal per day. We've got the TENS machine, which is basically just an electrical stimulant for our client. How TENS works is that we basically put the ends of the little electrodes over the area that hurts for your client, and we give low amounts of electricity current. TENS, sometimes people say it's really effective. Other times patients say they don't feel anything with it. So it really, again, just depends on your client. For TENS, this is usually done with physio. We don't really do it with nursing on the unit. We usually leave it for the physiotherapist. TENS is really good though for visceral pain. So if your client has the within pain, usually they feel a little bit better after the TENS machine. We then have heat and cold. So obviously if you're giving heat therapy, you're watching out for burns always. A tip for your guys is Rex. If it ever just says apply heat, that is never going to be your answer. If it is going to be heat, or if it is going to be your answer, it will be by protecting the skin or using something as a barrier to the heat appliance. If you just apply heat, you will always have a risk of burns, so it's never going to be your answer. Cold therapy, same thing. If it just says apply ice, it's not going to be your answer because you have to protect the skin. We're always looking for safety for your client in both of these cases. In practice, we should always be using, for heat, honestly, we never apply direct heat, unless if it's a warm blanket, which is already not very strong heat. We very rarely will apply a heat pad, unless if your client has one of their own. If they do, we will always put a towel as a shield almost, and then apply your heat. With heat, in the hospital setting, how long can we apply it for our client? Because they can't just stay on with their heat pad all day long. What do you think your time limit's going to be?
30?
It's actually even less, it's only 15.
Okay.
So safety for heat and cold will always be 15 minutes on, 15 minutes off, okay? And then we always go back and forth between it. And then of course we have our cognitive therapy as well. So this is going to be your distraction, that music, TV, games, whatever it is that we want to use. Cognitive can be effective for your client. Usually in our case though, we have acute patients, right? So in their case, you can try doing distraction, but it's probably not going to do much. Here you really want to give those the meds to your client and try doing something a little bit more aggressive. And then lastly, we have self-management. Self-management is going to be key for our clients, especially when they're discharged. So are they aware of how to take their meds? Are they aware of the side effects? Are they aware of farm, non-farm interventions to increase quality of life? Usually self-management, we usually see very heavily linked with our chronic disease management clients. Acute care, because it is such a short amount of time, usually self-management is pretty good for them because it's only for a couple of weeks. Chronic is where we see people that kind of go off their plan of the meds that we're supposed to give them. Any questions with pain? All right, here is your first mentee. So a patient is scheduled to undergo orthopedic surgery for a fractured femur. The healthcare provider orders pain meds. Which scenario would be most appropriate for initiating a PNB in this patient?
Can you read the code again, please?
The mentee
Yeah.
is 9384 4473.
Thank you.
It's 9384 4473. Last couple seconds. All right, so your answer here is going to be D. So let's go through it. We've got a client, they're going for surgery, ortho. Pain medication, which scenario is most appropriate for initiating PNB? So really, this is going to be the focus of our Rex question. Answer A is a patient with COPD requiring supplemental oxygen. Well, it has nothing to do with PNB, right? It doesn't contraindicate, nor does it indicate it. So we can just kind of leave that on the side. B is a patient with with a history of severe post-op nausea vomiting. Again, that's not really a reason for a PNB. C is a patient with a known allergy to local anesthetics used in PNBs. Obviously, we're going to avoid it. And then D is a patient who desires rapid and effective pain relief, which we know the PNB can give, with minimal opioid use, which we know the PNB is going to avoid. So D is going to be our best answer. Does that make sense? Perfect. All right, fluid and electrolytes. So this should be a recap from your guys' patho. I am going to simplify it to really just demonstrate ICF versus ECF, because I feel like so many students get them confused. So, fluid and electrolytes. When you look at this, you've got two big types of body fluid. You've got intracellular fluid, which is inside the cell, and then you have extracellular fluid, which is outside of the cell. go to the board and create you a beautiful picture. So we're gonna pretend this is the blood vessel, okay? Here is the cell within the actual blood vessel. So here, your ICF is going to be the fluid within, and then your ECF is going to be the fluid outside. So whatever is within the vessel. Whenever we do blood work, we are always taking blood work from ECF. We really can't tell what's in the ICF of our patient unless if we do really intense imaging, really intense blood work, which really we don't do ever in acute care unless if your client has a certain type of cancer. Other than that, all we need to know is that we will always assess ECF. So you know when you do blood work and you get your electrolyte values, those are all from your ECF that you see. They're never going to be intracellular numbers. So that's the first thing I want you to understand. Then we're going to break down our electrolytes. So I pulled this off of Lewis. I really like it because it shows you what you find where. For you guys, in order to make it super simple, I want you to see that sodium and chloride go together, and potassium and phosphate go together. Phosphate is what? It's a mineral, it's bicarb, right? So phosphate and bicarb are basically, in this case, to simplify it, the same thing. When you look at your electrolytes, it breaks it up, plasma versus intracellular. So, my ICF is going to have the most amount of what? Potassium. So, I'm going to make a new vessel. Inside my cell, I have more potassium. Outside of my cell, I have more sodium. Okay? You will see this because when we give fluid, what type of fluid do we normally give? Normal saline, which is sodium chloride. That makes sense because our ECF is only sodium and chloride, right? So that is why our electrolytes are really important for us to know. So yes, ICF versus ECF, but really it's potassium versus sodium. That's what we're looking at when we look at our fluids. This goes over why we have fluid shifts. So really, I won't go over all of them, but in general, if we ever have a change to the capillary or the interstitial pressure, you will then see the potassium and sodium starting to go back and forth. That's really what this slide is going to demonstrate to you. When we look at fluid shifts, we are focused on two of the extremes. What are the two extremes to fluid shifts? What are we going to see in our clients? Sure?
Or dehydration.
Beautiful. So you have edema versus dehydration. And that's always what we are trying to fix, right? Or prevent. So we either have isotonic in the middle, and then you have edema and dehydration on the sides. So now let's look at our shifts themselves. So ECF is going to equal water deficit. So if I take it to the board. So we've got our first point here, which is an increase in ECF. If I am increasing my extracellular fluid, I am increasing it over here. The only way I can increase there is if I decrease my intracellular fluid. Does that make sense? Yeah?
I was gonna say it helps to know that's like water and sodium have a reciprocal relationship, so if water increases, then the other sodium's gonna go down.
Say it one more time for me.
If the water increases in the ECF,
Yeah?
sodium's gonna decrease in the ICF.
In your ICF, exactly. So sodium and water, they have a bit of a following relationship. Does that make sense? So if you ever get too much water in an area, then usually you're leaking out sodium. Is that what you're trying to say?
Yeah.
Perfect. So you're absolutely correct there. So if I have increased ECF, I'm going to drop my ICF. If I drop my ICF, that means I'm losing fluid to the vessel itself, right? So what's going to happen to over here? It's gonna shrink. So now I've got a smaller cell, and then I've got a lot more fluid on the outside, okay? That's what we're going to see. This cell, is it going to be fluid overload, or is it going to be dehydrated?
Dehydrated.
Dehydrated, but can we see it?
No.
So we can't see it, that's the thing. So we are going to treat the ECF. What's my ECF going to be? You're going to have edema. So here, we are going to see edema in our patient. So then we're going to treat the edema, because remember, we can't see the cell, right? The cell doesn't exist to us because we just can't see it. So we're going to treat what we can see, which is the edema for our client. Does that make sense? Perfect. Your cell, in this case, you're going to have a change of osmosis. Your cell is then going to shrink, but your client is going to be edematous. That's the key there. If we swap it and we decrease ECF, we then are going to pull water into the cell. So what happens to my cell? It's going to be huge, and what happens to my water? There's very little fluid left. What am I going to see in my patient? Dehydration, exactly. So all of the signs and symptoms of it. But the cell itself is going to be swollen, it's going to be very enlarged. Does that make sense? Yes? Is that clear why we look at the two different types? Yes, you have ICF versus ECF, but ultimately we are treating ECF. Yes, we care about ICF, but we can't change the ICF. We can only change the ECF for our patient. If my client shifts back and forth edema versus dehydration, we've already talked about our volume issue. What else? What's our next big symptom we're going to see in our client?
For this scenario specifically?
In any scenario, when we have a big shift in fluid, what's going to go first? What's your first alert
Sodium.
that your client is having a fluid issue? It's LOC. It's always LOC. Your client's first thing that's gonna go will always be neuro, because the brain will either swell or it'll shrink, because the brain has so much ECF in it. Okay, so it's always neurological. Afterwards, when you do your weight changes, you do your blood pressure, yeah, sure, you're going to see changes, but ultimately the big thing we need to always assess for is neuro in your client. If the neuro starts to go, you know your client's going to decompensate. Does that make sense? Yes? Okay, beautiful. We can talk about the changes right now. So whenever we see a volume change, how do we assess it, other than neuro?
Did you say by weight too?
Weight, what type of weights do we do? What's the order gonna be? Is it every hour, every 2 hours, every day, every week, every month? Every day, right? So this is where your patient will be ordered a daily weight. How do you do a daily weight? When do you do it?
Oh, in the morning.
In the morning, before breakfast, right? So that's gonna be your most accurate before you get any of the fluid that we put in from the day. So we do our daily weight. What else can we do? You could do blood work. Electrolytes, absolutely. What else can we do?
Urine,
You could do urine. What are you looking for?
output,
Output, perfect. What's that order going to be called? Not your PVR,
bladder scan,
not your bladder scan,
Lysis.
not a 24-hour urine.
Give us a hint.
It's just your in and out.
Oh.
That's it. That's all that's gonna be ordered, right? But what's gonna be attached to it? Because they're not just gonna say check-ins and outs. What are they gonna say? Not catheter. How often?
Bladder scan?
No, not bladder scan. How often are we checking ins and outs?
Every hour?
Every hour, because we know it's gonna be a fluid issue. So we're not gonna wait 4 hours before we assess it again. we're going in and we are doing our ins versus outs. Ideally, it's equal. If your client has edema, we want hopefully your intake to be less than output for them. And then vice versa for dehydration. So we did our daily weights, we did our ins and outs. The last thing that we're going to, well not the last thing, but your last big assessment. Say it again.
Sorry, I didn't hear your question.
Your last big assessment for edema shifts. You could do skin, yeah. So what about the skin are you going to assess?
Pitting edema.
Exactly, your edema, right? So we do edematous checks all throughout. And if there is edema, we scale it 0 from non-pitting, +1, +2, +3. What else are we going to assess? Vital signs. What is going to change? Your blood pressure and your heart rate, exactly. So blood pressure and heart rate are always going to shift. If your client's edematous, what happens to the blood pressure? It goes up. What happens to your heart rate? It goes up, right? Because now your heart is pumping even more because you have so much more fluid to push. If the heart rate starts to go down, but your blood pressure remains up, is that okay? No. What does that indicate? What are they gonna go into? Shock. Bingo. So that's why your vital signs are going to be crucial. If you know your client is overly edematous, how often do you think we'll do vitals? You could do it every 15 minutes or every hour, right? At least once an hour we're assessing. If your client is just, let's say, +2 pitting edema, but other than that they're okay, then usually just every 4 hours is when we will reassess the vitals. Does that make sense? Yes? Okay, beautiful. All right, this next slide is going to go over our fluid spacing. Fluid spacing, to make it super simple for you, you have 3 types. Your first spacing is actually just normal. I don't know why it's even a type. It's just homeostasis. It's a normal individual where they have no extra edema on their body. Second spacing is where we have a mild amount of edema. So this might be someone who, when you palpate their feet, you feel some sort of edema, but it's still not pitting. Or maybe it's pitting +1, but that's really it for them. Your last one is third spacing. Third spacing is where you have severe amount of edema in your client. Third spacing is where your fluid is trapped. So even if you give your client some Lasix, it's not touching your third spacing client. What's an example of third spacing? The most common one that we'll see.
Is it like a patient that has CHF?
CHF, give me, specifically, where would that spacing be?
Oh, no clue.
Oh.
Third spacing? Maybe the
fluid
abdomen?
could be trapped. Usually it's like lower extremities, or if their heart failure is severe, you might see when they're protecting lungs.
Absolutely, so for your heart failure, it's the lungs. If it's in the feet, we can usually diurese it, right? So that's still gonna be second spacing. Where else can we see third spacing?
Abdomen?
Abdomen, what's that called?
Ascites?
Ascites, bingo. Ascites is where someone is really, really distended, and when you touch their stomach, it feels hard. Sometimes it's rock hard because inside it's just fluid. You give them Lasix, it does nothing. It touches none of it. The only way to remove it is by draining it out, which we will talk about in our GI lectures. Does that make sense?
Yeah.
Beautiful. Oh, actually, let me go back. I forgot to say. When is third spacing? When can we anticipate it? So heart failure, we can anticipate. Who else can we anticipate third spacing with? Renal failure, you could actually, yeah, renal failure, second especially, but your recs, you have to know the values. They will say sodium is this number, potassium is this number, and then they'll give you a scenario. You have to know if it's normal, high, or low. So please know your values when you start prepping for your recs. We've got sodium and ECF here once again. Again, ECF is really our focus because we are going to be treating the ECF. If your client has too little ECF, remember that means your cell itself is expanded, but your patient's going to demonstrate as what?
Dehydrated.
Dehydrated, exactly. And then it's going to swap when your cell is very, very small, but then your patient's going to be fluid overload, right? So they always go opposite to each other. That's what this picture is trying to show you. All right, let's look at some nursing diagnoses. So if your client has volume excess, we are going to see fluid overload, sometimes resulting from excessive sodium intake. So sometimes in the hospital, we can cause our patients to go into ECF if we keep giving them high amounts of sodium chloride. Maybe they don't need it anymore, but we keep pushing it in. We can force them to swap. So we have to be very careful about how much sodium we are putting into your patient's body. This is also where diet plays a really big role, right? If your patient is constantly eating processed food or anything with high amounts of sodium, you will find that they are just swollen in general, right? So they usually have that puffier look on them. Of course, we're going to see impacts to our respiration, so we can see inadequate airway clearance, and that's usually because they're retaining their secretions. So if your client has lots of fluid, and let's say all of a sudden it gets into their lungs, they're going to have a hard time to actually cough it out and get rid of it. What does that put them at risk for? Pneumonia, perfect. We already know there's going to be a risk for edema, and then our possible complications are going to be pulmonary edema and ascites for your client when we look at that third spacing. Volume deficiency, this is where we have a lack of fluid volume, so this is going to impact our cardiac output. And then your biggest complication here will always just be hypovolemic shock. If they don't have enough ECF, it impacts all of the organs, so they all start to fail at the same time, which is why shock occurs so quickly. This slide goes over our nursing considerations. I pulled this straight from Lewis. I really liked it because it goes over our big, I guess, assessment things that we are going to look at. So ins and outs we already talked about. Cardiac monitoring, we talked about blood pressure and heart rate. We can also include ECG changes for your patient, and this is usually going to be associated with heart failure. And then we have our JVD. What is JVD?
Jugular vein distension.
Beautiful, and why would that show up? Why would my patient all of a sudden get JVD? Does it just come out of the blue?
No.
It's after what?
It's just like the last thing where it's like, yeah, you're dying now.
Not that, it's not you're dying now. You could be very close to it though, you're absolutely right.
Like excessive muscle breathing, no?
Say it one more time.
Excessive breathing, like excessive muscle breathing.
Yeah, you could, but yeah,
Is it with collapsed lung?
not a collapsed lung. What's JVD going to be a result of?
Or ventricular,
Yeah, simplify it for me. Simplify it. What are you talking about?
heart failure.
Heart failure, bingo. So first your client's going to have a heart change, and then the JVD will present, because all of a sudden the heart is no longer able to pump, therefore the fluid starts to build up. That's when we see the JVD in our patient. Resps. What are my lungs gonna sound like? Crackles. You can possibly see wheezes as well, right? So we're gonna see both of them. Shortness of breath, of course. This can be shortness of breath on rest or with exertion. Weights, we talked about skin assessment, we talked about a little bit. When we look at skin turgor and tenting, how do we assess that? Show me on yourself. area that we assess as well. Your patient will usually have dry mouth, or they're going to have lots and lots of secretions, one way or the other. If your client has a dry mouth, not much we do, right? We give them a little cup with like, you know, the little green sponge thing, the swabs, and we just let them dip it in and they can rub it around and suck on it. If your client has lots of secretions, what is your nursing considered?
Suction.
Suction. We have suction on with the yonker, it's at bedside, and it's going. Beautiful. All right, now let's talk about potassium. So we've kind of neglected it because we don't really fix the ICF. But ICF will still have systemic changes in your patient. So we know that majority of the potassium is going to be inside of the actual cell. What does potassium help with? Your heart. Why does it help with your heart?
Does that help keep it like
Contractility?
Yeah, why is that?
It helps with the contractility.
Your contractility of all muscles, not just heart. Heart is the one that we see because we do the ECG, but remember, it impacts all of your muscles. Potassium is also crucial for your metabolic stores. So whenever you have a glucose or an insulin issue, usually potassium is also off in this patient. When we do our assessment, if it's hyperkalemia, that means we are losing potassium from inside of the cell to the outside. We've talked that, or we've already identified that potassium is inside of the cell. So why the heck is it hyperkalemia if my potassium is outside? Why is that deemed as hyperkalemia?
Because when you do the blood test, you're gonna take the blood from
Outside the ESF.
Exactly. When we do our blood test, we take it from here, right? So if my potassium is lacking in the cell, I can't tell. What I can tell is what's in the ECF. So in hyperkalemia, you have a loss of potassium to the ECF. In hypokalemia, it's when you assess the ECF, you can't see any potassium, it's probably all stuck in the cell. Okay, so that's going to be the difference between the two. Remember, we always test ECF only. There's no way of us testing the ICF. If I've got a potassium shift, what is the biggest thing that I need to assess for?
Oh, their heart.
Your heart.
Arrhythmias?
So what am I asking for?
You're looking for arrhythmias, changing the ECG?
Absolutely. You're looking for your arrhythmias, you're looking for your ECG or your EKG. Here, our nursing diagnoses, we are going to see in hyperkalemia, dysrhythmias as our complication, and we know there's going to be a risk of injury. Remember, we have now altered muscle contraction, which is a big issue. In hypo, we are going to see muscle weakness and hyporeflexia for your patient. And then again, your same complication will show up where it's dysrhythmias. Really, for both of them, it's always going to be muscle issue and heart issue. So we're always assessing for both. Our nursing considerations. So here, if your client is hyperkalemia, then obviously we are going to limit how much potassium your client is intaking. If they're hypokalemia, we will then give them potassium. We can give potassium through our IV fluid, which is potassium chloride, or you can even give them potassium chloride pills. So we will usually do one or the other, depending on how low their potassium actually is. What is my normal range for potassium?
3.5 to 5.
3.5 to 5. So if my client is sitting at a 3.4, I'll probably just give them a pill and see if it helps, right? My client's sitting at a 2, you're definitely starting IV on them. So it's always going to depend on how much off range they actually are. And then the EKG or the ECG monitoring actually goes for both hypo and hyper. So please pop it into that hyper column as well. When we give KCL into the veins, what are we always worried about? Like when we give it IV?
Phlebitis,
Phlebitis, why?
because it's irritating to the veins.
KCL is very irritating to the veins. A lot of times we will see that we will insert it and we'll start running it and then it'll actually blow the vein. So it's very important that we reassess that IV site for your patient. Alright, now let's move on towards our IV fluids. You have three types of IV fluids. You've got isotonic, hypotonic, and hypertonic fluids. If it's iso, let me actually pop it on the board. Alright, so this is going to be, I'll do my regular one here. This is my cell. So if it's isotonic, whatever's going into the cell equals whatever's coming out. So my cell will never change side. It will always be equal. When it's hypotonic, I've got my cell here, but all of the fluid is rushing into it, okay? So my cell is now going to be quite enlarged. That's my hypotonic. When it's a hypertonic, I've got my regular cell, but think of someone who is super, super hyper. That's how I always remember it. Especially kids, really hyper kids, they're usually quite thin, right? So my cell is exerting so much energy, it is going to become very small, and honestly, it usually looks really dehydrated, like a dehydrated grape, like a raisin. So that's really how you're going to see the three different types of fluids. You've got iso, which is equal, hypo, where the cell becomes very big, and hyper, where the cell becomes very, very small and shrunk. The reason why you need to know this is because it impacts the fluids that we give. So normally we love our NaCl, right? So our sodium chloride. We also love ringers. Both of these are going to be isotonic fluids. So this is going to be for our client who is already homeostasis. We then have hypotonic versus hypertonic fluid. So hypo, we are going to try to give to our client who is what? Fluid overload or dehydrated?
Dehydrated. Right?
Overload.
Fluid overload, right? Because remember, you're going to push that water into the cell. So if my client is an edematous, I'm going to give them a hypotonic solution. And this is usually the one that we go with, is usually the 0.45 NaCl. D5 half normal saline is also a good one for hypotonic. You can give either or. Hypertonic, this is going to be for what? Edema or dehydration? Dehydration. So this is going to be your client. Usually if there's no potassium imbalance, then we will give sodium 3% or D10W. What does that D stand for? Dextrose. So what do we have to watch out for if we give dextrose?
Sugar,
Your
glucose.
sugars, absolutely. So if your client's diabetic, we're a bit iffy about giving dextrose, right? Because then we might swing their sugars, and now you have to balance it out with what?
Insulin.
Insulin. Perfect. Does this make sense?
Yep.
Yes? Beautiful. Here is your next question. It's supposed to be select all, but I don't think you guys can do it on your end. But we'll go through it. So you just select one, and then we'll go through all of them. So a nursing student is studying the different type of IV fluid solutions. Which of the following statements would require a follow-up? C. So D is actually not your answer. So let's go through it. You are studying for the different IV fluids. Which of the following statements would require a follow-up? So what is this question saying? Which of the following statements are what?
Wrong.
Wrong, exactly. So, isotonic solutions, yes, so please, so whenever in your question it says requires a follow-up, that means either there's a complication or it's wrong. You're looking for two of those things. So the first one here, isotonic solutions have an osmolarity higher than plasma. That's false, right? Because what is it? It's homeostatic, it's equal, right? So A is incorrect. B is hypotonic solutions cause cells to shrink. Is that true?
No.
We know it's false because hypo, the cell becomes larger. Hypertonic solutions are commonly used to replace fluid losses. Is that true? No, it's also false because it's usually given for exactly. Dextrose solutions provide calories and are typically used
That's
in
true.
maintenance fluid. So let's look into it. Is dextrose giving you calories?
Yeah.
Why? It's
Sugar.
And is it used as a maintenance fluid?
Yes.
Which one? What's it called? No. What's the IV fluid called? D5W. Beautiful. So D is actually correct. Okay? Does that make sense?
Yeah.
Whenever you see require a follow-up, you are assuming that this answer is wrong or there's some sort of complication that you need to follow up on.